Hello, this is Dr. William Woods, clinical assistant professor at Oklahoma State University in the internal medicine department, and I'm going to talk about how you should be documenting a complete examination per CMS guidelines. Starting off with general principles, if it's not on paper, it hasn't been done. Proper documentation is required for accurate and timely patients. Also, it is the document that people reference when trying to find information about the patients, including consulting physicians and primary care physicians when they leave the facility. Healthcare payers require documentation of the site of service, the medical necessity and appropriateness of the testing or therapeutic services that you're providing, and they want the services furnished accurately reported to them. So medical necessity is one of the sections in our H&Ps that is incredibly important for CMS billing. As you know, the medical record should be complete and legible. It should include the reason for the encounter, the relevant history, the physical exam findings, prior diagnostic test results, the assessment, and the plan. You should be stating when you're doing the physical examination, when you're recording the document, and who you are as a provider. The rationale for the diagnostic or other testing that you're doing or the therapeutic services that you're providing should be documented. If they are easily inferred, you don't have to document it. So, for example, if they have anemia and you're following the CBC, you don't really need to state why you're ordering a CBC. Past and present diagnoses should always be accessible to the treating and/or consulting physician, and the appropriate health risk factors or comorbidities should be identified within the document. When you're documenting their diagnoses or assessments, you should be documenting their progression as well and their response to treatment or changes in the treatment plan. You should also state any revisions of previous diagnoses. So with evaluation and management services documentation, there are two primary guideline documents. That's the 1995 and the 1997 document. They do have differences, and I'll explain the differences as we go through. Determining the level of service from a documentation standpoint includes three different components that they evaluate, including the history, the examination, and the medical decision making. They allow for time-based billing in reference to counseling or coordination of care visits. In regards to history, there are four different sections: chief complaint, history of present illness, review of systems, and past history, including past medical and surgical history, family history, and social history. With billing, there are four different levels, including problem-focused, expanded problem-focused, detailed, and comprehensive. For this brief summary, we're going to talk about a comprehensive history taking. This is just a repeat of what I stated on the previous slide. Those are the four sections. With chief complaint, you need to state it in every document. You should be stating it in the patient's own word. You should not be using medical terminology for this section. In regards to that, you shouldn't be stating respiratory failure as the chief complaint. You should be stating shortness of breath or cough or whatever the patient complained when they first came in. History of present illness is the chronological description of the development of the patient's symptoms from their first sign or symptom to present day, or if it's progress notes from the previous encounter to now. There are explicit elements that they are looking for in the history of present illness, and those are location, quality, severity, duration of symptoms, timing of symptoms, context as far as when they start, when they end, what's going on at the time, and any modifying factors, including provocative or palliative. So what makes them better or worse, and then any associated signs or symptoms, associated review of systems. So per guidelines for the history of present illness, you must have four or more of those elements included. With the 1997 guidelines, if you're doing a routine follow-up examination, you can also just reference 3 different chronic conditions and what state in care or treatment they are in. With review of systems, they have very explicit systems that they recognize, including constitutional symptoms, eyes, ears, nose, throat, mouth, all as one section, cardiovascular, respiratory, gastrointestinal, genitourinary, musculoskeletal, integumentary, including skin and or breast complaints, neurologic, psychiatric, endocrine, hematologic or lymphatic, and allergic or immunologic. For a complete examination, you need to be referencing 10 total organ systems, including what they came in for. A notation indicating all other systems are negative is permissible, and with that, CMS is assuming that you have gone through a complete review of systems and asked all of the relevant questions. From an education standpoint, I prefer that you explicitly state what systems you have inquired about, because it reassures me that you have done an appropriate review of systems, and it lets me know if you are asking the proper questions. As far as past history goes, PFSH is what they reference in CMS documentation. That is past medical surgical history, family history, and social history. You need to complete medical surgical, family, and social whenever you see a new patient, whether they're outpatient or inpatient, or when you're performing a consultation. If you are following up on an established patient, you need to hit at least 2 of these history areas. Preferentially, you're covering all of these for your document. This is a reiteration of those areas. They consider past medical surgical as one area, and then family history and social history. Per CMS guidelines, all of this information in the history section can be included in the HPI, but practically when you're performing documentation during your training here, we absolutely recommend separating these out, but it is not necessary per CMS guidelines. In reference to progress notes or follow-up on established patients, you do not need to re-record a review of systems or past history obtained during an earlier encounter, but you should be reviewing that information with the patient, stating that you have reviewed that information and updating any change in previous information. You should also be noting, and I think the EMR system does this for us, but you should be noting which review of systems or past history that you're referring. As is common in clinical scenarios, ancillary staff, including nursing staff, can obtain the chief complaint, history of present illness, review of systems, and past history, but you as a provider should be confirming that information and stating that you have reviewed that information. You should also be updating that information if your history taking has changed compared to what the ancillary staff has documented. If you cannot obtain a history, you should be stating why. So if they have encephalopathy, you should be stating as such. If they're intubated and sedated, you should be stating as such. Now we're moving on to physical examination. With physical exam, we're going to explicitly talk about a comprehensive exam, and this is where the biggest differences between the 1995 and the 1997 guidelines are. For the 1995 guidelines, you need to cover at least 8 organ systems, and you cannot reference body areas. So you can't state head or neck or extremities. You need to be just talking about organ systems, and I'll talk about which ones those are in just a second. For 1997 guidelines, I think this is the easier one to remember. You have to hit 9 organ systems with 2 elements each, or you can use body areas, but they are very specific in which body areas you can reference for a complete examination. I recommend looking at the 1997 document explicitly in the examination section, because they state which body areas, which organ systems, and what you should be performing on a complete physical exam. Talking about the 1995 guidelines, the organ systems that they allow are constitutional, eyes, ears, nose, throat, mouth, cardiovascular, respiratory, gastrointestinal, genitourinary, musculoskeletal, skin, neurologic, psychiatric, and hematologic/lymphatic/immunologic. For 1997 guidelines, they want you to reference these organ systems or body areas. And just as a reminder, 9 of these: constitutional, eyes, ears, nose, throat, mouth, neck, respiratory, cardiovascular, chest or breast examination, gastrointestinal or abdominal examination, genitourinary, lymphatic, musculoskeletal, skin, neurologic, or psychiatric. Notice in this section it doesn't state extremities and it does not state head. I really do recommend going through the 97 guidelines because they are very explicit on what they want you to document. As general rules, you can state normal findings, not any issue with that. You can move on to the next area. But if you state abnormal, you have to be explicit on what you're stating. Explain what is abnormal and be very clear about it. Moving on, this is predominantly what we're going to talk about in regards to assessments or plan and the complexity of the patient. So with the medical decision-making section, per billing, there are 4 different levels, and we're going to be talking about how to document to try and get that high complexity level. Most of the patients we see are very complex patients. So things that affect the complexity in this section include the number of possible diagnoses and the number of management options for those diagnoses that you have to consider. It also includes the amount or complexity of medical records, diagnostic testing, and other information that you have to obtain, review, and analyze. In regards to comorbidities and diagnoses, things that can cause significant complications, morbidity, or mortality increase the complexity of the patient. So takeaway from this slide is that you should be documenting all of the problems that you are actively managing during an encounter, and you should be stating how complex achieving that diagnosis has been, and then any management decisions you make. You should be documenting why you're making clinical decisions, and you should also be documenting what is going on with these diagnoses. So you should be stating whether or not they're improving, if they're worsening, if they're controlled, if they're uncontrolled. In regards to diabetes, if they're hyper or hypoglycemic. If you do not have an established diagnosis, but you have a presumed diagnosis, you should be stating it's a possible, probable, suspected diagnosis. You should also document the initiation, any changes, or any completion of treatment, including patient instructions, nursing instructions, therapy, including physical, occupational, and speech therapy, and changes in medications. If you're doing consultations, you should be stating which provider or group you are consulting with. In the inpatient setting, you don't have to be super explicit. You can say consult cardiology. We know that you're going to be talking about OSU cardiology because that's who is at our service. If you are in the outpatient setting, you should be stating which group you are sending them to because you have a plethora of options. With diagnostic testing, you should state what you've ordered or when you're planning on performing certain diagnostic testing. In your plan and assessments, you should be reviewing laboratory radiology and diagnostic testing and noting what you are finding. So if you're following a patient with an active infection, you should be stating whether or not the white blood cell count is improving or worsening, whether or not they're still having fevers, etc. If you have decided to obtain old records or additional history from family members or caretakers, you should state who you've talked with, where those records are from, and what information you've obtained. That significantly helps in stating the complexity of the diagnosis and the process to obtaining a diagnosis. You should also document any laboratory or radiologic or diagnostic testing that you have personally interpreted. So with radiology, if you are reading the chest x-ray, you should state that you're interpreting it and what findings you have. If you are analyzing laboratory data, such as calculating fractional excretion of sodium or calculating transidative versus exudative pleural effusion, you should be stating that you are doing those and interpreting the data. So talking about how to properly document assessments and comorbidities, the easy one to talk about is diabetes. So with diabetes, you need to explicitly state what type of diabetes they have, type 1, type 2, medication-induced, etc. You should also be stating whether they are requiring insulin or are not insulin dependent. You should also be talking about any complications from that diagnosis. So with diabetes, it would be complication of diabetic retinopathy, diabetic polyneuropathy, chronic kidney disease, circulatory complications, including coronary artery disease or peripheral arterial disease. And then in addition to that, you should state whether it's controlled or uncontrolled with hyper or hypoglycemic episodes. You can do this with any variety of diagnoses. It's just really easy to talk about type 2 diabetes since it's a very common one in our patient population. Talk about when you're planning a surgical or invasive diagnostic procedure and why. And then if you are doing a procedure note, you need to be stating what the procedure is and whether it is diagnostic or therapeutic or both. So easy example in this is a thora or a paracentesis. If you are doing a paracentesis, you need to state whether it's diagnostic and you're obtaining lab or therapeutic and you are relieving symptomatology with it, or both. There's an explicit cutout for encounters that are predominantly coordination of care or counseling based. In this section, you basically have to state how long you have spent coordinating care or performing counseling with the patient. There are a few other sections when you're an attending physician that help with billing if you state what time spent on this has been. So with discharge, there's a difference in billing for less than or more than 30 minutes of time spent during discharge. With critical care time, there is a requirement to state why they're requiring critical care and for how long you have personally dedicated in the critical care unit to that patient, including review of laboratory data, interpretation, and active management. So billing for that starts at 30 minutes, and then after 60 minutes, you can bill an additional 30 minutes indefinitely, as long as you are stating what you are doing. That is, I believe, it for this. These are my references: Evaluation and Services Management Guide, the 1995 Documentation Guidelines, and the 1997 Documentation Guidelines. Like I said, I want you to review the 1997 Documentation Guidelines because with the examination section, they are very explicit about which body areas or systems to go through and what they want you to be performing on a physical exam. They also reference single organ system exams. You can take a look at that if you want. I think it's a lot more confusing and not as relevant to an internal medicine specific service. But that's it for today. If you have any questions, you can reach out to me on Cortext, through email, or through my cell phone. Like I said, this is Dr. Woods, and have a good day.